made this possible our mentors, our colleagues, researchers, and most importantly, coffee. Kasi kung walang kape, I don't know how we would survive rounds, much less this lecture. Also, a special thank you to the Philippine Heart Center, 50 years of training doctors, saving lives, and of course, giving us traumatic memories of 24-hour duties. Happy anniversary. So, why myocarditis matters? Before we dive deeper, let's first define myocarditis because understanding what we're dealing with is the first step in managing it effectively. Myocarditis is an inflammatory disease of the heart muscle, the myocardium. This inflammation can impair the heart's ability to pump effectively, leading to a wide spectrum of clinical presentations. Now, this is where it gets tricky. Not all cases look the same. Some children may be completely asymptomatic, while others can rapidly deteriorate into heart failure or, in the worst case, sudden cardiac death. It's a condition that doesn't always give us a fair warning and why it remains a diagnostic and management challenge. So as we go through this discussion, one key takeaway I would like to impart is myocarditis can be unpredictable. And in pediatrics, where patients can't always articulate their symptoms, our job as pediatricians, as pediatric cardiologists, is to recognize the subtle warning signs before it becomes too late. Myocarditis is like that silent backstabbing friend. You don't see it coming until it's too late. It accounts for about up to 42% of heart failure cases in children. 42%. That means nearly half of our pediatric heart failure cases could be due to inflammation. Now, looking at the PPS case registry, we have a total of 4,925 recorded pediatric cases of myocarditis out of a total of 5 million. Now, I know that might seem like a small percentage, but the real challenge is recognizing how many more cases go undiagnosed or misdiagnosed due to its variable presentation. These numbers emphasize early recognition, timely intervention, and continued research, which are all crucial. Because when it comes to myocarditis, what you don't see can hurt you. So, who or what is the culprit? More often than not, it's viruses. Coxsackie virus, adenovirus, parvovirus B19, and most notably recently in the last years is SARS-CoV-2. These guys love inflaming heart muscle like it's their favorite hobby. But let's not forget the non-infectious causes, autoimmune diseases, toxins, and hypersensitivity reactions. Basically, the immune system sometimes decides to go rogue and attack its own heart cells. Kung minsan, para daw toxic ex mo, wala ka namang ginagawa pero sinisira pa rin ang buhay mo. So, alright. So how does it show up? The short answer is like every other viral illness in kids, but sneakier. Looks just like a common viral infection. Fever, yep, just like a regular flu. Fatigue, of course. Every sick child looks very tired. Nausea and vomiting, classic stomach bug vibes. Cough and fast breathing could be a simple respiratory infection, or is it? But here's the sneaky part. The heart is involved. The patient starts to present with exercise intolerance. The kid who used to run around now gets tired too quickly. Chest pain and palpitations, rare but can mimic a heart attack in older children. Syncope, fainting. Not just dehydration, the heart might just be struggling. Heart failure signs like swollen belly, difficulty breathing, poor feeding in infants. So what's the lesson here? Pediatric myocarditis hides behind common viral symptoms, but adds heart-related flags. If a kid's flu comes with chest pain, trouble breathing, or sudden weakness, don't assume it's just a regular bug. It might be their heart asking for help. Time is muscle, literally. This is why we must maintain a high index of suspicion, especially when a child presents with unexplained tachycardia, persistent respiratory distress, or signs of heart failure without an obvious cause. If we don't think about myocarditis, we will miss it. Ultimately, recognizing myocarditis early can make the difference between a fully recovered heart and one that is permanently damaged, or worse, one that stops beating altogether. Given how unpredictable and potentially fatal myocarditis can be, the real challenge lies in how we diagnose it quickly and accurately. Because if we can't recognize it in time, we risk missing the window for intervention. So, how do we diagnose myocarditis today? The answer lies in a combination of traditional and emerging methods, including gold standard like biopsy, new biomarkers, and even the latest artificial intelligence technologies. So, the endomyocardial biopsy is considered the gold standard for diagnosing myocarditis. It allows us to directly examine myocardial tissue, confirming inflammation and ruling out other causes of cardiac dysfunction. However, it's not a perfect test. It's invasive, carries potential complications, and its sensitivity varies due to sampling errors. Since myocarditis can be patchy, biopsying the wrong area may lead to false negatives, meaning we could still miss the diagnosis despite performing the procedure. Because of these risks, EMB is not done routinely. It is reserved for cases where getting a definitive diagnosis is critical for management. Class 1 indications include new onset unexplained heart failure of less than 2 weeks duration and those unexplained heart failure of between 2 to 3 weeks associated with dilatation of the ventricle and unexplained ventricular arrhythmias or EV block. So when do we not do EMB? So we don't do biopsy in patients who are stable with mild myocarditis who are improving clinically, and patients with viral myocarditis where PCR-based testing on blood or imaging is sufficient for diagnosis, and for those patients that are asymptomatic or minimally symptomatic cases where biopsy risk outweigh the benefits. So, okay, biopsy is invasive. So what else can we use? Biomarkers. We have our usual suspects, the troponins, the BNPs, the N-proBNP, CRP, ESR, and viral PCRs. Basically, troponins tells us if there's heart damage. Parang nagsusumbong na ang puso na, Dok, sinaktan ako. BNP, that's the heart shouting, ayoko na, napapagod na ako. Meanwhile, CRP and ESR, well, they're your overreactive friends that love to react to everything. While these biomarkers do not replace biopsy, they help us screen, risk stratify, and guide clinical decision making. By combining troponins, BNP, inflammatory markers, and viral testing, we can improve our diagnostic accuracy without subjecting every patient to an invasive procedure. So let's talk about the cardiac MRI, the non-invasive detective for myocarditis. Why is it so important? There's no biopsy needed, no needles, no risks. Monitors disease progression. It tracks healings over time. It guides treatment, helps decide if we need to be more aggressive, and predicts outcomes. It detects scarring that may impact long-term health, particularly development of arrhythmias. So why is it so great for kids? Pediatric patients can't always describe their symptoms, and biopsies are very risky. Cardiac MRI gives us a clear picture without invasive procedures. So my final takeaway for cardiac MRI is that if myocarditis is the mystery, then cardiac MRI is a Sherlock Holmes solving it without a single incision. So how do we actually see myocarditis on cardiac MRI? Let's break it down. So the key CMR findings include T2 weighted imaging, which shows edema or swelling in the heart. Early gadolinium enhancement tells us there's inflammation and leaky capillaries. Late gadolinium enhancement detects fibrosis or necrosis, meaning damaged heart tissues. So when do we diagnose CMR-confirmed myocarditis? If a patient has clinical symptoms, chest pain, arrhythmias, or symptoms of heart failure, and their MRI shows these characteristic findings, we can confidently say, hey, this is myocarditis. So while cardiac MRI is a powerful tool, it's not a magic wand. We use it wisely, considering the clinical picture and definitely availability. And that's why it's just one piece of the puzzle in diagnosing myocarditis. Now we have two main tools to confirm myocarditis depending on the patient's condition. We have cardiac MRI if the child is stable and can tolerate imaging. And we have endomyocardial biopsy if it meets level 1 indication. If there's vascular access, need for more definitive proof, or concern for other diagnosis. The final step is putting those two together and making the diagnosis. So if the cardiac MRI shows inflammation, T1, T2 mapping, your early and late gadolinium enhancement, or the biopsy confirms myocarditis with the presence of lymphocytic infiltrates, a viral PCR, and signs of inflammation, we have our answer. So One thing or an emerging thing that we're looking at in the management and early diagnosis of myocarditis is the use of artificial intelligence. AI is basically revolutionizing this diagnosis like your most masipag fellow with unlimited coffee, never tired, and always analyzing cases. So for diagnostic enhancement, AI has been able to um, show echocardiogram analysis. It helps detect abnormalities early even if your ultrasound skills are still doc pang practice mode pa lang po ang echo ko. Think of AI as the consultant who never misses a finding, minus the merienda breaks. Outcome prediction, AI models can predict in-hospital mortality better than traditional methods. It's like a built-in huwag mong baliwalain yan, doc, alarm system, flagging high-risk patients before they crash. For ECG analysis, they are able to spot subtle ECG patterns we might overlook, leading to earlier diagnosis and intervention, less second-guessing, more timely treatment. Final thought, AI is here to assist, but not to replace that. Let's be clear. AI is not here to replace us. It's a tool. It's not a boss. And at the end of the day, it can process data and find patterns, but it still can't handle one, a difficult family conference, two, reassuring a panicking mother, or three, deciding when it's time to stop aggressive intervention. So while AI is a great sidekick, the real superheroes are still us, clinicians, nurses, and other healthcare workers who bring both science and compassion into patient care. Definition of myocarditis and the steps of diagnosis, including biopsy, imaging, clinical evaluation, let's categorize our patients based on the available evidence. So they are divided into four according to AHA. So one is biopsy-proven myocarditis, which is the gold standard, confirmed through endomyocardial biopsy. If a biopsy shows inflammation, infiltrates, and myocardial damage, we have a definitive diagnosis. If it's cardiac MRI confirmed suspected myocarditis, this is for biopsies that were not done, patients that did not undergo biopsy, sorry. And we rely mainly on cardiac MRI. And when the cardiac MRI shows edema, hyperemia, or fibrosis, then it's most likely myocarditis. And for the third classification, clinically suspected myocarditis, these are cases where the symptoms strongly suggest myocarditis, like chest pain, heart failure, uncontrolled arrhythmias, but we don't have confirmation from biopsy or MRI. Instead, we rely on good old ECG, troponins, and echo to guide our management. And for those that are classified under possible myocarditis, some features suggest myocarditis, but there's not enough evidence to be certain. For these patients, we try to be more vigilant with careful follow-up and sometimes additional testing over time. So for final takeaway, myocarditis isn't always easy to diagnose, but using the classification system, we can stratify patient and guide treatment decisions effectively. So on this, what do we do? First, you always support the heart. Monitor, admit to the ICU if needed, and start inotropes like milrinone. And then we have our anti-inflammatory strategies. We have steroids, IVIG, and sometimes even immunosuppressants. Basically, we tell the immune system, kalma lang friend, kalma lang, wait lang. For viral myocarditis, antivirals. But let's be real, sometimes the best antiviral therapy is just supportive care and a lot of prayers. So, for children with low cardiac output, our first-line inotropic agent is milrinone. And we love milrinone. It works by providing both vasodilatation and inotropic support, meaning it helps the heart pump stronger while also reducing afterload. And we're all about afterload reduction. This makes it particularly useful for maintaining perfusion in myocarditis patients without excessive vasoconstriction. Think of milrinone as that gentle but effective coach, giving the heart a push without putting too much pressure on it. However, when a patient presents now with shock, we bring in the big guns. Big guns include epinephrine and dopamine, but it comes with a trade-off. They can increase myocardial oxygen demand and cause arrhythmias. So while they are life-saving in cases of profound hypotension, we use them cautiously as they can sometimes make the heart work too hard. Essentially, milrinone is the preferred first move, but when the patient is crashing, let's use the big guns, just with careful monitoring to prevent rhythm disturbances. The goal of hemodynamic support is to maximize cardiac output while minimizing myocardial stress. We have to strike a balance because if we push the heart too hard, we may cause arrhythmias or further myocardial injury. And just to show the normal pressure volume loop of a healthy heart against a patient with myocarditis, the patient with a normal heart would have normal diastole, able to contract against pressure, ejects blood into circulation, and then relaxes before the next cycle. But if you look at the red line, this is what a pressure volume loop of a patient with myocarditis would look like. So the end systolic pressure decreases due to impaired contractility. So the ventricle fails to generate the same amount of pressure as a normal heart. Definitely, the stroke volume is reduced. And the left ventricular end diastolic pressure is also elevated because of impaired relaxation and increased filling pressures. The ventricle then experiences higher diastolic pressures, which contribute to congestion and heart failure symptoms. This shift in pressure volume loop tells us exactly what we see clinically: systolic dysfunction, reduced cardiac output, and increased diastolic pressures leading to congestion. Understanding these changes is critical because it guides our treatment approach. Since the heart's ability to generate pressure is impaired, using excessive vasopressors can actually worsen myocardial oxygen demand, much like um, sinasakal mo yung puso pag nagbigay ka ng masyadong vasopressor. Instead, we prioritize therapies that reduce afterload and support contractility. Additionally, the elevated LV and diastolic pressure means that excessive IV fluid loading can actually worsen congestion. This is why myocarditis patients require careful fluid management, and in severe cases, we may institute diuretics, or our next steps include mechanical circulatory support. So, Dr. Why milrinone? Now that we understand how myocarditis disrupts normal cardiac function, the next logical step is to discuss how we can optimize hemodynamics in these patients. One of our key pharmacologic tools that I've mentioned time and time again in the past 3 slides is milrinone. So, let's break it down. Exactly how milrinone modifies ventricular mechanics as shown in these pressure volume loop. So, for panel A, this is blue, which is milrinone initiation, and red would be a patient with myocarditis. So you can see that using milrinone reduces end systolic pressure that suggests decreased afterload. There's increased stroke volume, which means more efficient ejection per beat, a lower end diastolic pressure, less congestion, and improved ventricular relaxation. This shows us that milrinone improves both contractility and relaxation, making it a great option for myocarditis patients with both systolic and diastolic dysfunction. For panel B, heart rate. Unlike some inotropes like dopamine or epinephrine, milrinone does not significantly increase heart rate. And this is crucial because tachycardia and myocarditis can increase myocardial oxygen demand, worsening dysfunction. Milrinone gives us the benefit of enhanced cardiac output without overworking the heart. And for panel C, it shows how milrinone affects the systemic vascular resistance. So milrinone is not just an inotrope, it's also a vasodilator. Notice how the afterloading effects is reflected in the pressure volume loop with the leftward shift of the end systolic pressure volume relationship. By reducing systemic vascular resistance, milrinone helps the heart eject blood more efficiently, making it particularly useful in patients with high afterload. And for end systolic elastance, as seen here, improve contractility because most of the time patients with myocarditis have ventricular stiffness, and with milrinone it increases EAS, making the left ventricle now able to contract more effectively. And for the last one, overall the stroke volume is increased. So final takeaway, why do we love milrinone? Milrinone just has a lot of things that help a patient with acute myocarditis. In particular, these 3 things: inotropy, lisotropy, and afterload reduction. So, if we focus only on hemodynamics without addressing the underlying inflammation, we're just treating the symptoms, not the cause. This is where immunosuppressive therapy comes into play. Primary immunosuppressive agents we use are corticosteroids, which both have immunosuppressive and anti-inflammatory effects. They are particularly indicated where inflammation is more aggressive. Steroids may be used alone or in combination with other immunosuppressive agents like azathioprine or cyclosporine in severe or refractory cases. And our number one and most favorite medication again is IVIG. We call it the multi-action therapy. While not strictly an immunosuppressive drug, it has a unique blend of anti-inflammatory, antiviral, and immunomodulatory effects. The exact mechanism is still being studied, but IVIG is believed to neutralize viral particles, reduce autoantibody production, and modulate immune system overactivation. It is commonly used in suspected viral myocarditis and in the recent years for NIS-C. So, antiviral therapy is recommended when an active viral infection is identified as the likely trigger of myocarditis. However, this is where it gets tricky again. Many cases of viral myocarditis are diagnosed clinically without direct proof of viral presence in the myocardium. Despite this, antivirals are sometimes used empirically, especially if there's a clear viral infection in the patient's history. We should always consult our friendly IDS service in helping us with which antiviral to initiate. So, let's talk about how simple viral infection can turn into inflammatory cardiomyopathy in these three steps. So, step one, the virus attacks. It all starts with a viral infection. The immune system fights back by releasing antiviral cytokines to eliminate the virus. Step two produces three possible outcomes: viral elimination with healed inflammation, viral elimination with persistent inflammation, and chronic viral infection with or without inflammation. Step 3, clinical results. Depending on the outcome, we may see different conditions: healed myocarditis, dilated cardiomyopathy, inflammatory cardiomyopathy, or chronic viral heart disease. This helps us in initiating treatment strategies that we have discussed: antiviral therapy, immunosuppression, or just standard heart failure medication. So, despite our best efforts with hemodynamic support, immunosuppressive therapy, and antivirals, there are cases where the heart simply cannot keep up. When myocarditis leads to severe cardiogenic shock, conventional therapies may not be enough to sustain circulation. So what do we do when the heart is waving? Help me, please. That's when we consider mechanical circulatory support. Let's now explore the role of MCS in salvaging the failing myocarditis heart, when to initiate it, and what options are available. So this is a diagram that shows when to consider. So when the heart remains in heart failure despite maximal medical therapy, so they experience pulmonary congestion, respiratory failure, and high filling pressures, requiring continuous diuretics just to keep the lungs dry. Even worse, their left or right ventricular function progressively declines despite all our best efforts with inotropes and afterload reduction. At this stage, we all can think about ventricular assistive devices or ECMO, depending on their presentation and age. And this, in some cases, can either be a bridge to heart transplantation. Hello po, Doc. Do patients recover? Doctor, do they recover? Well, sometimes yes, sometimes no. Some kids recover fully while others end up needing a heart transplant. But the biggest challenge, donor hearts are rarer than a free than donor hearts are rarer than a free parking spot in BGC. So this does not also come without any complication. They're at increased risk of complication. They have limited myocardial recovery, and they have very high resource utilization and cost. And also, we have to think about the ethical and prognostic uncertainty. This is where the tough decision comes in. One of the biggest challenges is determining when to transition from temporary support to long-term solutions or even withdrawal of care. Prolonged mechanical circulatory support without signs of recovery creates ethical dilemmas regarding withdrawal of care, especially when recovery becomes unlikely. In these cases, we are faced with difficult conversations. When do we continue and when do we stop? These decisions involve not just medical judgment, but also family discussions, ethical consideration, and institutional policies. Beyond survival, even for children who survive, many are left with residual cardiac dysfunction, neurodevelopmental delays, or psychosocial challenges due to prolonged ICU stay. So these patients do not just need a beating heart. They need regular, frequent follow-ups and lifelong medical care. Survival, they say, is just the first step. These patients will need multidisciplinary support coming from pediatric cardiologists, pediatricians, rehab, neurology, and other health services to help them adapt to their new reality. So again, mechanical circulatory support isn't just about keeping the heart beating. It's about ensuring that these patients have a meaningful quality of life after survival. This is why early discussions about long-term goals, prognosis, and ethical considerations are critical in guiding care decisions. And when all therapies do not give us an answer, medical therapies, inotropes, and even mechanical circulatory support fail to restore the cardiac function, we reach the final option, heart transplantation. And for end-stage patients with myocarditis, transplantation is not just a treatment. It's their only chance at survival. But as we'll see in Dr. Priya's talk, it comes with its own set of challenges, risks, and long-term considerations. So we've discussed in a nutshell, pediatric myocarditis, its presentation, etiology, its challenges, and limited access to imaging. So, the world is moving fast. AI-driven diagnostics, next-generation transplant programs, and well-established programs are becoming the standard in developed countries. But here in the Philippines, we face unique challenges: limited access to advanced therapies, financial constraints, and a scarcity of transplant programs. ECMO and VADs are not widely available, and heart transplantation remains a rare option due to logistic and donor limitation. The gap between what's possible globally and what's feasible locally is something we need to address. Because while we may not have the same resources, we have brilliant minds, innovative clinicians, and a resilient healthcare system that continuously find ways to improve patient outcomes. So the real question for all of us today is, how do we bridge this gap? So for conclusions and future directions, myocarditis remains a tough challenge, especially in a resource-limited setting like the Philippines. But there's hope. AI-driven diagnostics, and the challenges the Philippines must step up. Innovation and advocacy are key to ensuring access to advanced therapies, and the future really lies in research, in the use of biomarkers, precision medicine, and expanding heart failure care will drive progress. My final takeaway is collaboration, research, and healthcare investment will shape the future of myocarditis care. The tools exist. Now it's our job to make sure no patient is left behind. So the future is bright. Let's make it happen. So